Well, it's been 5 minutes. Welcome back, everyone. And I hope you did take a moment to just get up. It's hard to sit all this whole time, and our bodies were not meant to sit so long. But we appreciate your joining us this morning. So let me introduce to you my boss. All right. So his name is John Barrett. Dr. Barrett is a board certified physician executive with huge experience leading system level strategic initiatives and collaborating with diverse teams of hospital, medical group, and health plans executive leadership in an academic medical system. And he has also extensive experience in urgent care, medical management, evidence based medicine, and digitally innovative practices, both within the scope of a network of community based health centers, as well as being virtually accessible across the state of Utah and surrounding region. I can attest to the fact that he will answer any text that is sent to him. Please
Don't say that.
don't talk about it. But versatile communicator, comfortable with performing high impact presentations, as well as leading business critical negotiations at an executive level. So welcome, Dr. Barrett.
Oh gosh, thank you so much, Yvette. And I just want to say that we're so pleased that the department can host this incredible AHEC program. In a world of such pessimism and talk about burnout, things like that, it occurs to me that already this morning there's reason for great optimism with folks that work for AHEC, our legislators who are here today, people like Jose who are also involved in the workforce effort, really doing great things. And the future of the state of Utah is bright in this area. So we'll keep the effort going. And thanks for the mindfulness activity. That was great. It's a little intense. You're right to be sitting and listening. I have, without further ado though, I have the pleasure of introducing Dr. Chris Johnson, our keynote speaker today. Dr. Johnson is a board-certified emergency physician. He is an advocate for public health, and nationally recognized author and expert on the prescription opioid and heroin epidemic. Now, he's been at the front lines of this. He's been an emergency physician for 20 years. He was the chair of the Minnesota Department of Human Services opioid prescribing work group for 6 years, from 2015 to 2021. And he's a board member of Physicians Who Are Responsible for Opioid Prescribing. That's a national organization to promote new approaches to this health disparity. He's a real content expert here. He had a TED Talk that I encourage you to view. It's from 2018. It's about the opioid epidemic. The title is "The Medical Industry Created a Public Health Crisis." It's been viewed tons of times, very viral on TED, and over 96,000 views on YouTube. He argues that the opioid epidemic isn't really an accident. It is a systemic problem created by circumstance, the medical industry, and poor incentives. This created this crisis really at the expense of effective and compassionate science-driven medicine. The point I took away from video two is that this complex problem is going to require multifaceted solutions, which I think dovetails really well with what we heard. We heard about clinician training, we heard about workforce and staffing, and we heard about reimbursement from Steve, and we just, everybody really values all those efforts, and it's going to take all of that coming together to really bend that curve in mental health and particularly in substance use disorder. Dr. Johnson has given many presentations at various conferences and settings, including the FDA, law enforcement settings, as well as public health organizations. We're really happy to have him give our keynote address for the 9th Annual Utah AHEC Primary Care Summit. Please joining me in welcoming Dr. Chris Johnson. Chris, take it away.
All right. Well, first of all, can everyone hear me? This is a bit of a new experience presenting virtually like this. Typically, I would be in some sort of stage and on engaging with the audience directly. So this is it's a bit of a different experience for me, but we're all, you can all see and hear me.
Gotcha.
Excellent. Well, actually, I think I got up to 100,000 on YouTube at this point. So it only took 6 years to get to that. Of course, Adele gets to 2 million within a day. So I have to keep my, manage expectations in terms of becoming famous, which is the goal of any good physician is to become famous. But I am very grateful and delighted to be participating in this conference today to talk about a subject that I have been involved with, boy, almost 20 years now. Back in my just initial days in the emergency department, long before Prince died. And I'm very also pleased that this is actually the second time I've been asked to give a presentation this year. Now, I haven't given a talk in up till now. Had been 4 years. Now, there was another public health issue that came up in the last several years that quite justifiably took the headlines and maybe pushed the opioid epidemic from the front page. But COVID, aside from the tragedy of over 1 million Americans lost to that, did teach us some things actually about addiction and about opioids that I think actually makes this talk even more complete. And especially given the nature of this conference and the public health professionals that are involved in this, I actually think the insights that COVID helped bring about actually gives us more opportunities to intervene to try and improve the situation. A little background on me. I am an emergency medicine physician. I'm actually not originally from Minnesota. I trained at the Medical College of Virginia in Richmond, Virginia, and I grew up around the Washington, D.C. area. And like most Americans, after you finish your undergrad medical training, you're wondering, where can I go for 5-month winters? Well, you can go to Minnesota for those. And that is exactly what I did. And I moved to Minneapolis to train at Hennepin County Medical Center in 2000. And I never left. And I am still here. And what you see up there on the screen right now, that's Hennepin County Medical Center. That's where I did my training. And that's where I became introduced really to the problem of substance use overall. I mean, in residency is where we get our sort of crash course of clinical training. But Hennepin County is a county medical center. And for those of you who work in county medical centers and county hospitals, you know that you're often seeing a disadvantaged population. There's often a lot of social pathology, family structures that have been, disrupted, destroyed. Maybe some, parents are incarcerated. Employment is not steady, if at all. And I'll be honest, you could get a little bit dismissive about substance use in that setting because it kind of goes along with that patient population. But then in 2003, I moved my practice here. This is Methodist Hospital in St. Louis Park. And St. Louis Park is a relatively nice suburb of Minneapolis. And I did this in 2003. And what I saw there staggered me. I was seeing the same problems in St. Louis Park that I was seeing in downtown Minneapolis with the county. Now, not all the circumstances were the same, but I saw people with ongoing use of opioids, typically prescriptions, often high dose. And it came to the point where I couldn't go a shift without seeing some opioid related problem. Either a person who was on opioids for their chronic pain had come in with some, maybe they strained their back, lifting something, they had run out of their opioids like a week early, and that was a very common one. The other times I would actually see, people were frankly overdosing, and sometimes I could reverse them with Narcan. and sometimes they were completely non-breathing, and I would have to put them on a ventilator. And now and again, I couldn't save them at all, and they passed away very tragically. And when I started seeing this every day in this suburban county hospital, I became concerned that there was a much bigger problem happening here than just what I was seeing in my training at a county hospital, and that began my investigation into this. And we're going to talk about this today because even though COVID has, sort of receded, this public health problem is still a terrible epidemic. In fact, it might even be the worst it's ever been. So goals for this talk. The problem, what are opioids and what is the current state of the crisis by the numbers? And little spoiler alert, the crisis is about as bad as it's ever been. I gave a lot, most of my talks I'd actually probably giving around the year 2011, 2012. And that was when it was a quote crisis. Well, it's even worse now. How did it happen? I will argue that this was not an accident, that there were specific agendas involved in creating this crisis, not that the industry was looking to cause this epidemic of overdose and death, but they were looking to they had agendas about selling services and medicines, and the possible consequences were ignored at the time in the name of business. Why did it happen here? Other countries have seen upticks in their opioid usage with their populations and increases in the deaths, but in places like Germany or Japan or the UK, they didn't see anything like the kind of crisis we had here in the United States. So I'm going to discuss why was the U.S. healthcare system particularly vulnerable to an issue like this. What can we do about it? Now, obviously, the goals of conferences is we want to know what can we do. I will state very frankly that this problem is too big, too complicated, too many stakeholders that we're just going to get a couple bullet points and we're good. Okay, it would be a disservice to the extent and depth of this problem that we can just sort of go through this, and this, okay? But I will discuss some things that we can do. And I want to talk about treatment of this crisis, both on an individual level, as an addicted individual getting treatment, but also as a societal level, understanding that there are societal components to addiction that make the population more vulnerable. And this gives many people involved in the healthcare and social support system opportunities to intervene to help our patients. Final take-home points. I will argue that all opiates are heroin and all humans are on opioids. And as a consequence, we need to stop talking about addiction in terms of morality. This is not a question of morality. This is physiology of the brain and reward system that we all depend on, and it's vulnerable to distortions, but has nothing to do with your character. So the problem, what are opioids and why are we talking about them? Well, the use of opioids as a medicinal substance for the treatment of pain goes basically as far back as we have written civilization. The use of these as analgesics goes back to ancient Greece and ancient Egypt. And the classic way or the historic way of using this substance was you took the milk from the seed pod of the opium poppy, Papaver somniferum, and I put a little picture up there for you. And what you did historically is with the seed pod, you made this sort of slice in the side of it, and you could collect this milky substance. And in there, you had about 12% morphine, which is our active ingredient. And again, this is the opium poppy, Papaver somniferum, and just for historical interest purposes. Somniferum comes from Roman mythology. Somnus was the Roman god of sleep and first appeared in our literature with Ovid's Metamorphoses, which all of you remember, was the 15-volume epic poem in Latin which detailed the history of the world from the beginning up until Julius Caesar. And I thought the first 10 volumes flew by, actually. It was the last 5 that I'm like, oh, come on, you've got an army, let's get to the Rubicon, you take the city. But what you did with this milky substance is you kind of dried it out, and in there you've got the morphine plus a little bit of codeine. And that's what the internet says dried opium looks like. And because it's on the internet, I believed it and put it in my presentation. Also, the morphine, that also is a reference to mythology. Morpheus was the Greek god of dreams. Now, the way opium treats pain is as two pathways. One pathway actually does involve decreasing the strength of nerve transduction into the dorsal root of the spinal cord. But the primary way we are talking about pain control with opioids, which can lead to the problem of addiction, is that opioids make you feel good. Now, this slide here is a dramatic oversimplification, and those who study pain and those who study, I mean, I understand that this chart is very oversimplified, but one of the main pathways is to opioids increase the release of dopamine in the reward system, and thereby elevate your mood and therefore affect your experience of pain. And what we need to understand is that pain is an emotional experience, sort of like all of life is. And your emotional context greatly affects your experience of pain. My mentor at Hennepin County Medical Center was a doctor by the name of Jim Miner, who was specialized in sort of pain management, sedation, and became a department chair. And he would give the example when he gave talks related to this issue of stubbing your toe. It doesn't seem like a terribly dramatic injury, but you can have very different reactions to it. In one circumstance, it's, you're a busy physician or provider. It's early in the morning. You're kind of running late to work. You're looking for your car keys. You're trying to collect your laptop, and maybe you've been up all night. Maybe you've got a 1-year-old, and your 1-year-old's got a fever. They've been crying. I don't have children, but I've heard of them, and your rest is not very high on their list of priorities. And so you're exhausted, and in the course of running around, you accidentally kick the coffee table, and you just let out a string of profanity. And that experience will likely color your entire day. And contrast that with another experience where maybe you're out for dinner with friends, you're at a restaurant, it's relaxed, you're having good food, good times, and you excuse yourself to use the restroom, and in the course of crossing the dining table, you accidentally kick a chair. And you don't even notice it until the next morning. And you look down and it's black and blue, and you're like, oh my goodness, that was harder than I thought. So your emotional context dramatically affects your experience of pain, and opioids affect your mood, and therefore they can be effective pain control medications. But they carry significant risk, and we all know this. In high enough doses, opioids can slow or even stop your breathing. And unless action is taken to either reverse or support your breathing, if the breathing stops, you've only got minutes before you have irreversible brain damage from asphyxia. And then what follows often is cardiac arrest and death. So why are we still talking about this? The short answer is we're still talking about this because we still got a crisis on our hands. The United States contains about 4.5% of the world's population, yet we consume just under a third of the world's opioids. We are outliers in terms of the population of kind of what we just call the developed countries, OECD countries. We consume about 3 to 5 times as much opioid as the typical European. And this didn't used to be the case. We experienced a massive increase in opioid exposure in the late 90s to 2000s. Between 1992 and 2012, the number of opioid prescriptions tripled. And not only did they triple in terms of just the number of prescriptions, but the size of the prescriptions went up as well. That is the amount of opioid within each tablet that was given to the patients. And then as we increased the opioid pill exposure in 2010 and 2015, we developed new phases to this. Back up until then, we were talking about an opioid prescription crisis, which is true. But in 2010 and 2015, we had the emergence of heroin and then subsequently fentanyl, which added to our opioid exposure and tragically to the deaths. Okay, now some have argued that the prescription opioid problem is over, and I will argue that there isn't a separate opioid crisis. That's all the same crisis. We just have different faces of it now, because 3 out of 4 users of illicit opioids, such as heroin or fentanyl, began with prescriptions. That is often, I don't like the term gateway, but it is the introduction that people can psychologically get over that hurdle. People rarely just go straight to heroin or fentanyl, but pills prescribed by a physician, that they can do. So the consequences of this massive increase in exposure to opioids is that we've had a terrible overdose death crisis. And this is like the most recent, I think the data's gotten even worse since then. This goes up to 2021, where we had over 80,000 overdose deaths due to opioids. I think it's up to like 85,000 now. But I would also want to draw your attention to the years 2020 and 2021. Between 2019 to 2021, we had like a 50% increase in overdose deaths, and that coincides with COVID. And again, I mentioned a bit about the public health nature of the opioid crisis, and we're going to talk more about this because that was the largest 2-year jump in the history of the opioid crisis, and it wasn't an accident. This is understandable. We talk about the waves of the opioid crisis, okay? And right now we're in the 3rd wave per se, and that is the fentanyl. The fentanyl became a problem starting in 2015 and now corresponds to the vast majority of the overdose deaths due to opioids. But I still want to point out, as you look at this curve, and I don't know, I don't know if you can, all right, there's this curve here of the prescriptions, which is sort of in this green here. I'm pointing at 2012 to the, all right, here we are still at the 12,000, 14,000 level. We are still at crisis levels of deaths from prescriptions. You know, we don't call it that crisis now. It's only been superseded, but we still have the same number of deaths from prescriptions that we were still all up in arms about back in 2010, 2011. Since the opioid epidemic began, we've lost over 500,000 Americans to opioids. As I mentioned, about 85,000 in 2023 alone. And if you want to know what 85,000 deaths looks like, it's about 28 World Trade Centers. Back when I gave this talk initially in the 2010, 2011, it was simple. I just had the slide with 6 of these. I thought that was outrageous. A little did I know that 10 years after that, we would look at if it was just 12,000, like, oh my, well, what if we got back to that, what great progress we've made. We'd be very reassured by that. And this is the level of the crisis we're at right now. 500,000 Americans is the number of US soldiers lost in World War I and World War II combined. Now, how and why did this happen? No one has been spared this crisis. Probably the most prominent person lost, and certainly from my state, Minnesota, is the death of Prince. That was in 2016. But we've lost athletes to this. We've lost other artists, actors, and they are, you know, celebrity sports figures, celebrity athletes, but they aren't any more tragic than all the people we've lost in our neighborhoods, in our families, and friends of our families. And I'm going to argue that American medicine, in my observation, has changed dramatically since I was a medical student, and in the practice I've experienced over the last 25 years. The pharmaceutical industry and the corporate imperatives of American medicine dominate the marketplace and dramatically influence how care is delivered, not always with the best consequence for our patients. So the industry's goal in the late 1990s was to favor increased use of prescribing of opioids for chronic pain. And they had to change the culture, which was very reluctant to use opioids in those circumstances. It was mostly reserved for those hospice patients, for example. So the message that came out of the opioid manufacturers and a number of the pain physicians was that chronic non-cancer pain is an undertreated epidemic, and opioids are the answer to that, and they are safer than we historically have thought them to be. And they used a direct approach, very specific, well thought out approach to try and accomplish this. And they used 4 primary tactics. Tactic 1, recruit pain specialists. The pain specialists are, especially those at academic centers, are kind of the faculty that we as regular workaday physicians look to help teach us our best practices. And the opioid manufacturers recruited them to be their champions, to influence the rest of us to increase our prescribing, and we trust them. We have to trust our faculty. As any person, you go through your training, you can't reduplicate all the trials in medicine that have taught us what is safe and effective. You simply, it's just not possible. You have to just trust that the data you're getting is the best data that was ethically obtained, rigorously vetted, and is safe for you to use for your patients. And so we have this inherent trust that is where we're getting our information. And one of these pain specialists has become a little bit infamous is this doctor, Dr. Russell Portnoy. Now, he was subject of the Wall Street Journal article, "A Pain Drug Champion Has Second Thoughts." This is from December 2012. And he sought to rehabilitate the medical community from opiophobics, those who had an irrational fear of opioids. And he was the president of the American Pain Society for a number of years, including 1995. We'll talk about that in a second. And he began his career as a pain specialist who worked with hospice patients. And he quite rightly looked at these hospice patients and found that those who were dying of cancer and these chronic irreversible illnesses often suffered needlessly when increased, more liberal use of opioids would provide them relief. And so I would say his career began in a very reasonable and compassionate manner of treating these patients, but then he sought to, well, if this type of chronic pain could be managed with opioids, could we do it for other types of chronic pain conditions? And this is when it kind of went off the rails. In the American Pain Society, they are the ones who came up with the idea that pain is a vital sign. And I remember this was a button that I actually wore in my residency, and my faculty wore it, saying that pain was almost unacceptable. And if a patient was in pain, you were borderline negligent in your medical duties to that patient. They were suffering as a consequence. You were not treating them properly. But and then their pain level was to be treated as of such consequences to their outcome as blood pressure and temperature and heart rate. But it should be noted that pain levels are reported, vital signs are measured, and that's a very you can say your blood pressure is 300 over 250, but it isn't, and we can measure and determine that. But I've had more than a number of occasions where a patient's pain was 100 out of 10, which is you're in pain, but the number itself doesn't have much meaning. In 1996, Dr. Portnoy authored a position statement that was published in the Clinical Journal of Pain, representing a number of the position of pain physicians, stating that the risk of addiction was less than 1%. The risk of addiction for use of opioids for chronic pain was less than 1%. Now, okay, where did that come from? I mean, that sounds pretty reassuring. Well, that less than 1% statistic came from an article published in the New England Journal of Medicine in 1980. So what should stand out to you is you should be a little bit suspicious already, because 16 years after this was published, they said, oh, that New England Journal article, yeah, that showed that opioids were non-addictive. And 16 years later, that's a little odd. So what was this study published in the New England Journal that showed that? Well, bear with me as I go through some tables of statistics and methodology and peer review, and I'm kidding. It was a 5-sentence letter to the editor. This is what they were referring to in that less than 1% statistic. This was not a study. This was 5 sentences of an observation. And what Porter and Jick did was they went through about 12,000 records of patients who received at least one dose of a narcotic while they were in a hospital for an acute injury, and then followed them up afterwards. And they noted that addiction was rare in those types of patients. But it said nothing about the safety and efficacy of using opioids on an ongoing basis as an outpatient to be used indefinitely. Nothing. And this was the great failure in my view of medical ethics and the industry itself. You look retrospectively at this group of patients. That is, and Dr. Portnoy also published case studies of like 30-something patients who are using opioids chronically, and they seem to do well. And case studies and retrospective studies like this are what we call observational studies. And observational studies are useful. You say, okay, so it's this could be safe, and maybe this category of patient can use it safely, okay? But they're the beginning of the scientific process. They're up here. This is observation. Question, can these medicines be used safely and effectively on an ongoing long-term basis? Generate your hypothesis. I think these can be safe. And then you do the experiment. You test it with a double-blinded randomized controlled trial. You follow up for at least 6 months, probably more likely year to 2 years and ongoing. And that experiment was never done. Or at least it wasn't done until 2018. And we'll talk about that actually a little bit later. But 2018 was 25 years after it should have been done. And we've borne a terrible consequence as a result. So what does Dr. Portnoy say about opioids now? Well, in an interview in 2010, he said, I gave innumerable lectures in the late 80s and 90s about addiction that weren't true. Clearly, if I had an inkling of what I know now then, I wouldn't have spoken the way I spoke. In that same Wall Street Journal article, though, they noted that millions had been paid to his clinic from opioid manufacturers. And I don't have to, you can imagine what happened to some of that money. The clinic pays him. My viewpoint is that I can have those relationships. They would benefit my medical education mission, my research mission, and to an extent, my own pocketbook. When I read that quote from Dr. Portnoy, I was reminded of this quote by Upton Sinclair, who wrote The Jungle, about the meatpacking industry. It is difficult to get a man to understand something when his salary depends on not understanding it. Tactic number 2, target primary care physicians and patients directly. This was never done by opioid manufacturers until 1996, and one product changed all that. OxyContin, made by Purdue Pharma as a continuous release preparation of oxycodone. And this OxyContin was produced to essentially replace or substitute for their other continuous release morphine product called morphine sulfate contin, or MS contin. Contin simply being a shortened form of continuous, a sustained release preparation. And so the patent was expiring on MS contin, and MS contin was quite profitable. And so Purdue Pharma, and this is not unique to Purdue Pharma, when they have what's called a blockbuster drug that's making in hundreds of millions or even $1 billion, when the patent expires and generics are about to happen, they come up with some other slightly different formulation and put a patent on that. And that's exactly what they did. Oxycodone was an old and unsexy, a very well-known and unsexy opioid that had been around for years and years and years, but they repackaged it with this continuous release formula and released it as this new, less addictive version of opioids. Now, why would you target primary care doctors and patients directly? Okay, well, the primary care doctors see the most patients by far, far more than the pain specialists. And you want to target patients directly because, previously continuous release opioids like MS-Contin had been used for hospice patients with advanced cancer. It wasn't going to get better. That is too limited a market. You can't make billions with hospice patients because, yes, the number of patients, it's not enough, number one. Number two, sadly, many expire. And they were looking for a way to get opioids to patients by the millions, and you can do that with back pain and arthritis. And so what began in the late 90s to early 2000s was this promotion campaign by the pharmaceutical industry, Purdue Pharma in particular, and they, through conferences, invited doctors and nurses and pharmacists, everyone involved in the supply chain of getting opioids from the manufacturer to the patient, wined and dined, to promote and incentivize the increased use of this medicine, and they did. They gave promotional materials both to the clinics as well as to the patients directly. One of the promotional materials was a video called "I Got My Life Back." It was a video distributed by Purdue Pharma, and it detailed the story of about 7 people who struggled with their chronic pain, their life, they couldn't do anything, and OxyContin was the answer to their suffering. And up here, you'll see I've included a screenshot from Anthony Bourdain's series called Parts Unknown. And this is from the Massachusetts episode that aired in November. I don't want to reduce that. No, maybe I will. In November of 2014, where he detailed his own history of addiction, specifically to heroin. And they got a hold of this tape. And as you can see, the representative up there is talking about the less than 1% become addicted. And we saw where that came from and how misleading that was. Oh, I'm sorry, hold on. Why is it not advancing? Does anyone know why this isn't advancing now? Oh, there we go. Can I be heard at this point? Can someone, I'm having.
Yes, doctor.
Okay. They also gave free drugs away. Now there was a rule at that time that you could not hand out free samples of controlled substances, and that's a very reasonable rule. So what the drug companies did was actually, well, if you can't give away free controlled substances, we'll give a coupon for the free substances. And so patients were given this coupon here for OxyContin, which was free. Now, tell me that doesn't sound like the creepy guy outside the high school with a bag of something, because here's for you, because I'm your friend. And over 30,000 used this program before it was canceled. But as you can see, like it was just nefarious the way they use those techniques to get people essentially hooked on this substance. Okay. Tactic number 3, influence in government and regulatory bodies to favor the increased use of these substances. Now, the primary body that they needed to influence was the Food and Drug Administration. And as we know, the Food and Drug Administration is responsible for approving new drugs for the treatment of a condition, or approving old drugs for a new indication. and they need to do testing to see, is this safe and effective? Now, part of the problem, however, is that the FDA is now greatly dependent on the pharmaceutical industry for it to function. And part of that dependence goes back to the 1992 Prescription Drug User Fee Act. Now, this act was born out of kind of necessity. Back in the late 80s and early 90s, we had the crisis of HIV and AIDS. And there was this clamor from the population that, we've got all these patients are suffering and dying, and we need to get medicines tested and get the, hopefully determine that they're effective to help these patients. And it was overwhelming to the FDA. And so the drug companies said that, well, all right, we'll do the trials ourselves, and we'll pay an application fee. Now, the problem is that over 25% of the FDA's budget comes from these user fees. And this is like hundreds of millions of dollars. And in 1995, under pressure from the pain physicians and the patients, the FDA approved the use of OxyContin and opioids for the treatment of long-term non-cancer pain. But the details of that approval are actually a little bit sketchy. And this involves the problem of the revolving door, which is you have often inappropriate close relationship between government regulatory agencies and the companies that they are actually trying to regulate. Now, if you're supplying the budget to a government regulatory agency, it is very difficult for them to say no. And even more so when the companies are actually contributing to individuals involved in the approval. And one such doctor was Dr. Curtis Wright. He was the team review officer for the FDA that recommended approval of OxyContin for the management of ongoing chronic to moderate to severe pain. Well, 2 years after the approval, he went to work for Purdue Pharma, and his first year compensation was over $400,000. So you could wonder whether or not he was, you could legitimately wonder whether that recommendation was based truly on the science or whether it was on self-interest. Tactic 4, blur the line between advertising and advocacy. The message about opioids for chronic pain is a lot more authentic and compelling, especially to government political leaders, regulatory agencies, when it looks to be coming from patients rather than drug representatives. But we need to be very cautious about this because look who's behind these patient advocacy groups. One such advocacy group was something called Partners Against Pain. And look at their logo here. Look, they're holding hands. Like Partners Against Pain is fighting pain and loneliness. And who would fight that? Or who would be against that? But if you scroll down to the bottom of the webpage, you'll see the logo for Purdue, okay? This is something called unbranded outreach. And so this group was actually sponsored by the drug company itself. And unless you think this is an isolated incident, this happens all over medicine. In fact, in March of 2017, the New England Journal did an investigation of over 100 patient advocacy groups, and over 80% of them received financial support, often almost complete financial support for the entire budget, from the drug and device companies that made products that treated that specific condition. So you can wonder, is this really the voice of the patients, or is this the voice of the industry? Are they just corporate mouthpieces? Some of these organizations have actually been shut down. Senate investigation of the American Pain Foundation found that was simply a mouthpiece for the opioid industry, and that was shut down in 2012. Another investigation shut down the American Pain Society in 2019 as a pawn of the pharmaceutical industry. And remember, these are the people that came up with the pain as the fifth vital sign. I would also like to be able to tell you that these are isolated incidents where maybe the pain societies have made allegiance with these corporate entities. But unfortunately, honesty prevents me from doing that. This is, again, widespread, including what I found about the American Medical Association. This is the largest, this organization is the largest voice of doctors. And I found this from their Board of Trustees meeting in 2019, their annual report. This details the corporate roundtable that they partner with. And included on their corporate council is Janssen Pharmaceuticals, which agreed to pay out over $4 billion and acknowledge their responsibility in creating the opioid crisis. Mallinckrodt, makers of Dilaudid, $1.6 billion. Teva Pharmaceuticals, over $23 billion. And this was, I am not some great tech sleuth. This is just something I could Google and find on the internet. It's embarrassingly easy to find evidence of these compromising relationships. And I say compromising because money is speech, but it's a special kind of speech. Money can buy behavior. And I say that as someone like, I don't go to work for free. And as a patient, this would cause concern because, you know, you want to trust that the person you're putting your health or life in their hands only has your best interest at heart, your health interest. And we have taken an oath for that. But we have seen study after study showing that money can legitimately change a doctor's behavior. Including this study in 2016, where something as simple as a $20 lunch could change a physician's prescribing practices. And we've even seen this regarding opioids. This was published in the JAMA Network 2019. One of the things that happened as a result of the Affordable Care Act was called the Physician Payment Sunshine Act, which made more transparent gifts and other payments directly to physicians from the industry. And so what these researchers did was they looked county by county across the United States regarding gifts by opioid manufacturers. And they found that when there was more gifts to doctors from these manufacturers, there were more opioid prescriptions written and more overdose deaths. Now, this doesn't necessarily determine causation, but it does show correlation, which given the other public health data should be very worrisome about cause worry about these relationships. Now, a number of you have treated patients with these conditions, and I've treated many. And I'll be honest, I've had a hard time finding great evidence that they've reclaimed their life. Okay. Now, you certainly couldn't tell that they reclaimed their lives from the people in that Purdue Pharma video that I mentioned before about the 7 people who said they got their life back. And you know why? Because 2 of the 7 are dead now, both in active addiction. One was found unresponsive in his home, another unresponsive after wrecking his car. And a third, actually, Lauren, who's here in the top right, acknowledges she became dependent, but was able to successfully wean from those medications. So I've talked about the way pharmaceutical industry use these tactics to change the culture of prescribing, affect the FDA, affect primary care physicians, directly market to patients. So they're the ones to blame, correct? In a large measure, I would still say yes, that they bear a great deal of responsibility for causing this crisis. But I would offer this caveat that the pharmaceutical industry sells everywhere. It is a global business. This crisis happened to an extent not seen anywhere else. Again, Germany, Japan, Australia. This crisis happened at an unprecedented level here in the United States. So why was this such a almost uniquely American phenomenon? Well, this is from my year-end performance review back in 2012. Those are my arms. I am very proud. Chris, we are also proud of the work you are doing with chronic pain, but it's such a fine line between increasing risk of opiate addiction and HCAP scores. That was from my medical director. And in case you're wondering what HCAP scores, I don't know how many are directly involved in that part of the healthcare industry, but HCARE scores are your patient satisfaction surveys. They are your Yelp reviews. They do not exist to make patients healthier. They exist to keep patients as a customer. Press Ganey and NRC Picker and others are these commercial entities that are sometimes hired by healthcare systems to administer these surveys. And in part of these surveys would be these questions. During this hospital stay, did you need medication for your pain? During this hospital stay, how often was your pain well controlled? During your hospital stay, did the hospital do everything they could to help you with your pain? Now, unless you think that this really is about improving health outcomes, if satisfaction scores were about that, then why do drug dealers also use them? If you haven't heard of it or haven't read it, I highly recommend the book Dreamland by Sam Quinones. This is a journalist and author who looked at the American opioid epidemic, paralleling what was happening on the United States side with what was being done by cartels in Mexico. And the fascinating thing was that these cartels were beginning to use American service economy techniques rather than just sort of, shooting things out. They were using pagers and they were responding to customer needs. And so they would often send surveys to their clients, the users. Was your driver polite? And if driver was sort of a jerk, you never saw that driver again. Maybe no one saw them ever again. Was the dope good? And if the response was, well, no, didn't quite do it for me this time. Often within an hour, knock, 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 on the door. They were there. Here's a free bag on us. Sorry about that. We'll try to do better in the future. The emphasis on customer satisfaction, which we sometimes see the phrase in the medical industry called the patient experience, which is just the customer experience, but substituting patient, is because medicine in America is first and foremost a business enterprise. And as every business has as its first priority is make money for the owners, the shareholders, or nonprofits, the bondholders. We call this fiduciary responsibility. And literally, one person's healthcare consumption, healthcare activity is another person's investment opportunity. And I argue that for this reason, America is not especially incentivized for your long-term health. It is incentivized to keep selling healthcare services. And I believe this causes a unavoidable conflict of interest. Why is that? Because healthy patients consume less healthcare. And this is set up to be a risk for an opioid crisis, because the system that is driven to sell services thrives when patients are in a state of chronic disease. And opioids for chronic pain was a terrific business model with these incentives. Pain is now an epidemic, and it's not just the hospice. Hospice patients, it's back and joint pain, and we got tens of millions now with chronic pain. So we expanded the customer base. Opioid pills solve the problem and are by prescription only. This, captures the market, okay? Because you have to come, if opioids for chronic pain, they're by prescription. We're not saying Tylenol is the answer. You can't just buy them over the counter. You got to see your provider. And such visits are often fairly quick. You can, sometimes, and I've seen records where these visits are done in 5 to 10 minutes, and another prescription and they're done, and another patient comes in and you can generate another bill. And treatment is indefinite. It's a stable market. Because opioids frequently cause dependence, patients come back over and over and over. So the American healthcare system, has a lot to be criticized for, in my opinion. And, I don't know if you can see this. I don't know if it's projecting or you're just looking at it on screen, but the United States is by far the outlier in terms of expense per years lived. In fact, if you've been noticing, we're actually on the downslope. Our longevity is going down in recent years, unique among the developed nations. You see Switzerland, Japan. I mean, it's expensive, but this is the cost per year of life lived, and it's on the horizontal axis. And you see, we are off the charts. We are the outlier. And so I would argue that, change has to happen to a healthcare system that results in an opioid crisis and results in that kind of cost per year of life lived. So this is a conference where we want to discuss what we can do. And like I said, I don't want to give the impression that simple bullet points and a talk for an hour can change a problem with so many stakeholders actually performing just fine with things the way they are. Okay, but there are things that we can do, and I'll argue for all of them. I would argue that we would want to treat substance use and addiction both as an individual illness and a societal illness. On an individual level, prevent new chronic opioid using patients, okay? And for those who already developed the pathology of addiction, best practices to treat those who have already begun that process of opioid addiction. Secondly, treat the society. What can we do? And again, we've got public health stakeholders. This is where public health can really affect addiction as well. What factors in a society can we intervene on that make people less at risk? So start one, prevention. If you're a provider and you're seeing a patient with chronic pain, do not start them on opioids for their chronic pain with the intention of just sort of leaving them on that. As this quote from Desmond Tutu reminds us, there comes a point where we stop pulling people from the river and start finding out why they are falling in the first place. So prevention. The study that I mentioned to you previously about the double-blinded randomized controlled trial looking at opioids and non-opioids for chronic joint pain, that was finally done in 2018 by this doctor, Dr. Aaron Krebs, who actually works out of Minnesota for the VA with a basic $2 million government grant. This study could have been done 25, 30 years ago, but it wasn't. And it wasn't because these drug companies didn't have a $2 million to do the study. They had just had no interest in doing the study, okay? Now, this was a randomized controlled trial, and it showed that opioids over the course of a year do not perform any better than non-opioids for the treatment of chronic pain, but they do show higher rates of complications, exactly what you would expect from the public health data that we've seen. And it doesn't take very long at all for a patient to develop dependence. A lot of the studies that the opioid manufacturers used back in the 90s only went 6 weeks to maybe 2 months. Well, that was long enough. They stopped the study then, but that was enough for many people to develop dependence. This study from the Kaiser Family Foundation in Washington Post in 2016 showed that a full third of patients who'd used the opioids for 2 months had developed dependence. Now, the good news. We have seen prescribing decline substantially since the peak in the 2011 to 2012 era of this crisis. So that has come down noticeably, and doctors have learned about the safety and efficacy of opioids. That's good. But as you can see, the deaths from synthetic opioids, fentanyl, are still going up. And that is because we still have the many millions that were exposed years ago and are still using opioids as a consequence of that exposure. So prevention, they don't work long-term. We've got good studies now showing that. Individual treatment part 2 is for those who have developed addiction, we want to do best practices. One of the best practices is medical-assisted therapy. And I will not speak to you of this with the expertise of an addiction medicine specialist. I am not an addiction medicine specialist. I'm an ER doctor who became involved in this because of the crisis I was seeing in the emergency departments where I was working. But medical-assisted therapy has shown a definite benefit. From the Annals of Internal Medicine, August 2018, they followed several thousand patients from the Massachusetts area who presented to the ER after a non-fatal overdose. And those who got started on medical-assisted therapy, whether it was methadone or buprenorphine, showed a dramatic reduction in overdose deaths in the next 12 months. Though it should be noted that not everything helped, and naltrexone did not show any mortality benefit at all. But I want to urge caution that we should not just rely on medical assisted therapy the way we would, say rely on insulin for a diabetic, okay? MAT or medical assisted therapy is not a cure for addiction. There isn't a cure for addiction. This is something that is going to be managed. It's part of what we should look at as a comprehensive solution. Just because there is no cure for addiction, I don't want to. People shouldn't be that pessimistic about things. There's no cure for many conditions in medicine, including diabetes. Insulin is not a cure for diabetes. It helps you manage your diabetes and live your life with diabetes. And we can look at addiction treatment in a similar fashion. Okay. But we need to be mindful that it's not this, okay, if they develop addiction, everything's fine. We got them on MAT. Because this study of addiction medicine in 2017 showed that once opioid use disorder develops, about 1 in 5 are dead within 10 years. And that's a terribly high mortality, especially for someone who maybe developed it in their 30s, okay? And it was an all-cause mortality study, which means they're not just looking at overdoses, because those who develop opioid use disorder often don't live healthy lives in other respects, and often can die of, like, say, heart disease. Rarely would they be also, they have an opioid use disorder, but they also happen to be a triathlete. That's rare. So when we want to prevent this again upstream, Narcan as a desperate second chance only. From a study from Brigham and Women's Hospital, 2017, Harvard, they followed the patients who had been revived with Narcan and found that 1 in 10 were dead within a year. That is about the mortality of someone in their 80s. Again, we don't want someone we want for them to not be in that spot in the first place. Now, I'm not arguing that we shouldn't make Narcan more available, because 9 in 10 were alive, and there's no reason not to give someone that second chance, even if it is a desperate second chance. It should be Prince, in my state of Minnesota, you may or may not remember, but his plane dove out of the sky because he was overdosing on the plane after a show in Atlanta, and he received a dose of Narcan in the ER and woke up and went home. He was dead within a week. Okay, so Narcan has its uses. It can be life-saving, but it doesn't stop addiction, and their patients are still really in harm's way. Other non-pharmacologic individual treatments have roles here, including psychotherapy, addiction psychiatry, pain psychiatry, peer support organizations. All of these components have a role to play. Peer support is very important, helping people understand that they are not alone with this, which again is very important for recovery. But there are limits to addiction treatment as an individual illness. Some very compelling statistics that I will point out to you is that the United States has about 10 times the overdose death rate as the European Union, yet we have 10 times the number of treatment facilities per person that they do. We have about over 14,000 for our population of somewhere like 330 million, versus 2,500 for their population of over 700 million. So we have the facilities to treat. The resources are not the problem. We also have more peer support than any other country, with a full 40% of Narcotics Anonymous chapters in the world in the United States. And as I mentioned previously, Narcan, absolutely, let's make it more available, but have no illusions about what it can accomplish. We've increased the exposure of Narcan by over 1,300-fold since 2012. And the death rates from opioids and fentanyl continue to spike. And I think that is because many users don't use with a quote-unquote spotter, okay? Often they'll use in their rooms or alone, with people who might also be incapacitated. And all it takes is a few minutes, as we discussed previously, of respiratory depression, respiratory arrest, and hypoxia before death from asphyxiation happens. But I want to argue as well that we need to think and act as addiction as a social disease. And I'll offer the fact that I am not the first person to talk about this. But I think we need to be very mindful of the social factors that contribute to this, and some data that has been published more recently and our lessons from COVID point this out. I highly recommend the book Deaths of Despair and the Future of Capitalism by the economists Case and Deaton. And one of the very interesting points of this book is they show that deaths of despair did not hit every population equally. What you can see here is poisoning, suicides, and death from chronic liver disease, which is alcohol, has been rising for the last 20 years. This is the chronic liver disease, suicides, and here's poisonings, and this is driven largely by opioids. However, white middle-aged Americans have been disproportionately affected, white non-Hispanic in the United States, especially those without a 4-year degree. You can see those the death rates from the deaths by despair for those with men and women. Men still outnumber women by quite a bit in terms of those that way to expire, but those with a high school degree or less by far experienced the most dramatic increase and affected by this crisis. Now, this is not a call for people to tell their patients, well, go and get yourself a 4-year degree and take on loans and stuff like that. What I think this points out, and what they make the case for in the book, is that society has been leaving this population behind, and they feel marginalized and ignored and less relevant. And that puts people at risk for these deaths of despair and self-injury, self-poisoning with drugs and alcohol. And then COVID happened, 2019 and 2020. And what lessons did we learn about addiction from COVID? Well, as I mentioned in that previous graph, we saw the highest spike in overdose deaths from opioids in the 2 years that COVID hit the population. A full 50% increase, highest ever in 2 years, from 50,000 to 75,000 overdose deaths from opioids. But it wasn't just the opioids. We saw a dramatic increase in alcohol sales and in alcohol-related deaths during the pandemic. And this is something that we're probably isn't that great a surprise, but the pandemic brought to light the social factors that put people at risk of intoxicants, things like food insecurity, financial insecurity. People were isolated, they were lonely, they were on lockdown. They could have maybe Zoom meetings with their family and friends, but that's not how we evolved. We evolved to be, spend time together. Boredom. Again, without activities, often without a job to do, you're just in your living space all day, not much to do. That's not healthy. That's, again, not what we as a species evolved to, how we're supposed to interact with each other and the world. All of these cause emotional distress and the allure of intoxicants, but they all represent opportunities for intervention. I think a fascinating case study of the social determinants of addiction can be seen by the Vietnam War. And there was this terrific worry about the addiction crisis that was about to come back to the United States. I think Nixon was president at that time, because a Department of Defense study showed that a full 20% of U.S. servicemen became dependent on heroin while in active service in Vietnam. This was like 100 times higher than the people who become dependent on heroin in our everyday life, in societal life in the United States. And that should automatically raise flags, right? Because how did a supposedly random draft somehow pull this population that was subject to addiction? And the answer is that it didn't. Okay, but conditions can make that much more likely. These people were taken from their homes. They had the long hours of boredom. They had threats to themselves and their self-integrity, which leads to the condition called PTSD, which has something like a 70% coincidence with addiction or substance misuse. And it wasn't just the fact that they were under threat. PTSD also involves a threat to your sense of self. And a fascinating study I read about this was that drone pilots actually have almost as higher rates of PTSD as infantry in combat conditions. And I couldn't figure out why that was. I'd always assumed, granted, I'm an ER doctor, I hadn't studied it extensively, but that it was the threat to you're not in control, you're in a dangerous situation, your threat to self was the cause of this. But actually, what traumatized drone pilots is that in many occasions they were given an assignment of they would have their one house that they would observe, sometimes for weeks at a time. And these pilots would see the heat signatures of the people living there, which often would include, say, women putting their laundry up and children playing. And after weeks of observing, they were given the order, okay, you take the house out now. And I'm not going to argue the necessarily rights or wrongs of that, because in a number of many of these, maybe all of them, they were cohabitating with a person who legitimately was hunting Americans. But a person who's a drone pilot asked that question: am I the kind of person that bombs a family? And that can cause the trauma that leads to PTSD, which is like a very high risk for addiction. However, what was seen in the Vietnam vets is that when they came home, rather than getting success at 5 to 10%, which was typical, their success rate was 90%. And after many went through the physical dependence treatment, they found that they didn't need the substance anymore. They didn't have that emotional connection to the substance that takes someone from dependence to addiction. They were back with a supportive family. They were engaged in their preferred activities. They were safe. They weren't asked to harm anyone. They weren't being under risk of threat themselves. And so they didn't need the substance. So this is where we have a real opportunity to intervene on a social level, is that nothing changes if nothing changes. And while we may put someone with addiction into a 30-day facility, they're going to get out after 30 days. And if they just go back to the same neighborhood, the same job or lack of job, in the same environment, and we just tell them, we'll do everything you were doing before, but just don't use substances this time. That may last a little while, but that's not a recipe for lasting success. So just say no is meaningless, okay? And it was always meaningless, okay? We need to do our best to help them say no. And that is what we should be doing as both healthcare providers, as well as social workers and other people who can intervene to make their environment as conducive to recovery as possible. So, final take-home points. The American medical system is not going to get us out of this, okay? As I mentioned, we spend more per year of life by far than any other developed country, and we have the worst outcomes. We've had this crisis for 20 years. You know, if we were going to solve it with the healthcare system, we would have done it by now. In fact, the healthcare system, by being this expensive, we create a tremendous financial burden on patients that puts them under strain, and financial strain is actually a risk for addiction. So we've got the most expensive and robust healthcare system with the most treatment facilities in the world, but the worst outcomes, okay? We can't just say, we can't trust the system with these perverse incentives to get us out of this. The other take-home point is that as far as the human brain is concerned, all opiates are heroin, and all humans are on opioids, okay? And a little historical note, heroin is not originally a street drug name, okay? Heroin actually comes to us from the good people at Bayer Pharmaceuticals, okay, which is a German pharmaceutical company. And they were looking to develop a morphine type drug that was less addictive than morphine, and they miscalculated a little bit. But anyway, the name comes from the German term heroisch, which means heroic or strong. And what they came up with that is because they gave this substance to patients and asked them how it made them feel, and that was their response. So they dropped the ish ending and added in, just like they had the term aspirin. then it became heroin, okay? But as far as the brain is concerned, it's just another opiate, and there's nothing special about it. If you look at these chemical structures I put up here on the screen for you, from morphine to heroin to oxycodone, hydrocodone to they're all structurally almost identical, and to the brain function almost identically, okay? The external appearance is meaningless, okay? Black tar heroin, looks dangerous, it's dark, therefore it's harmful. It's like, no. These pills are white as a snowfall or a wedding dress, and they can cause just as much death, destruction, and misery. Okay, the only thing that matters to the brain is the molecular structure. In fact, some countries actually use heroin medicinally. If you found yourself injured on a visit to the UK, for example, maybe you got a kidney stone, you went to an ER there, they would likely give you 2 milligrams of diamorph, which is heroin. And you should rightfully say thank you. That was compassionate pain control, okay? And the only reason any of these substances do anything is because we make them, okay? We are all on opioids, and they constitute a very vital part of our reward structure, which helps moderate our behavior and learning how to interact. We make opioids. These are the endorphins, and endorphin is just a contraction of two terms: endogenous, which means being made from within, and morphine, endorphins, okay? We're all on opioids all the time. And as such, we need to stop talking about this as a question of morality, okay? And here's where I would have some contention with some of the more traditional recovery programs, such as 12-step, which includes things like talking about a moral inventory and defects of character, okay? The Surgeon General has come out unambiguously against using such terms, okay? And we've created addiction in other species, okay? Alcoholism in chimpanzees, cocaine and heroin addiction in mice and rats, gambling addiction in pigeons, okay? We do not talk of these other species as having defects of character, and we should stop doing it for humans, okay? This is about brain physiology. If it wasn't about brain physiology, then you also have this to explain. How is it that with this marketing and sales campaign, did we have a sudden and parallel corresponding increase in the number of immoral people in this country? Or was it just a coincidence? I conclude with this slide here. This is the painting Despair by Edward Munch. Despair, espero is Latin for to hope, so despair literally means without hope. I don't advocate for changing how pain is treated with opioids because I want people with pain to suffer, okay? We just need to use good and ethical science, okay? And I understand the providers who can be very frustrated with these patients with chronic pain on chronic opioids, and they're asking for more, and they want the pain score's got to go down, okay? They can be very frustrating. I sympathize completely, okay? But anyone who knows and has worked with patients who have suffered opioid addiction and their families, it's a miserable place to be and can feel like it is without hope. And so I'm arguing here not because I want to punish, judge, or withhold safe, effective care and pain management, okay? I argue for changes both with prescribing and with the healthcare system because the truth is we all deserve better. We all deserve better. And I want to thank you for inviting me again today. And I guess we're question and answer, or are we taking a break?
Yes, Dr. Johnson. We will start the Q&A, and Prudby will read you the questions. Thank you.
Thank you very much, Dr. Johnson. We have quite a few questions in the Q&A. Garrett Schwank, one of our AHEC scholars, says, how does U.S. American opioid use compare to the global OECD competitors in context of rates of homelessness, income inequality, and other social determinants of health?
Well, what I would say is compared to many other countries, in terms of the social determinants of health, the United States is unfavorable. Now, I looked at something called the, does anyone know what the Gini index? Are you guys aware? That's an economic term, okay? It's a measure of income inequality among the population. And the United States is more similar to countries like Argentina and Peru, Brazil, in terms of the kind of income inequality. We like to compare or say the American myth of sort of, being raised by your bootstraps and, everyone can rise in America. It's a land of opportunity. Actually, we are among the more rigid in the world in terms of income inequality as a consequence of social mobility. So again, we are more similar to countries, again, like our South American neighbors than we are to countries in the OECD. As rigid as the United Kingdom, we are more rigid in terms of opportunity than places like Germany or Japan. In terms of organized society as overall like that, yes, we favor, I can't speak to the homelessness. I don't have that number offhand, but in terms of like income inequality, yes, we are significantly more unequal and rigid in our social structure compared to other countries in the OECD. I give a talk on gun violence too, by the way. And I mentioned, if you look at sort of gun violence in countries, you can, aside from the ease with which you can get firearms in the United States, you can actually draw maybe even a better correlation with violence and this kind of amount of inequality where you have lost social capital. And the loss of social capital causes increased risk for things like violence, as well as for levels of incarceration and overdoses. So in terms of the social determinants of health, yes, we are not, we don't compare favorably to many of those countries in the OECD.
Thank you very much, Dr. Johnson.
And look,
We have another question
Gini index, I think it's GI.
by our community health worker, Kathy Wilsfeld. Kathy asks, so you think that the opioid crisis was a targeted effort, targeting the underserved community?
I don't know if I don't necessarily they know that they could target an underserved community. These people they're business people. They want to sell to everybody. And if for those who have insurance and have they were perfectly happy to have those people take their product in, day out, week in, week out, every month. I don't know necessarily that they had that as their target, but I know their target was to maximize revenue. And if that, do as much science as they could kind of get away with to make it look like they were legitimately trying to, I mean, I will argue it's still a poor effort, and I don't hide my disappointment in my own profession with how this turned out. I can't say for sure it was targeting underserved. Obviously, underserved often suffers from these other social determinants that can put risk for addiction. But again, these companies wanted to sell to everybody.
Thank you very much. We have another question from one of our AHEC mentors, Dr. Dawn Satterfield. She's asking, how can nurses be enlisted to caution patients who are prescribed opioids about the powerful addictive potential and also painful illness that can result even acutely? As a nurse patient following knee surgery, it took both for me to realize what the drugs entailed for me, so stopped with that recognition. Wished I had been counseled.
Well, the nurses, I'm hoping can be enlisted in the same way that providers can be enlisted and encouraged to show, like, here's the data, okay? These medicines, especially after someone's had like a surgical procedure, like a knee replacement or something like that. Nurses in that setting in particular, and hopefully the doctors too, can explain to them, like, pain is going to be a consequence of this, and we're going to modify the pain as best we can within the first week, maybe 2. But that pain is going to be a part of the recovery process, and that the goal to eliminate pain may be impossible, but also is extremely risky. That if you use enough medicine to get rid of pain altogether, that is way too much. That is putting them at unnecessary risk, and that pain is part of the recovery process. And I would, again, this could be especially helpful in post-surgical patients who are going to experience pain and quite reasonably get at least a temporary dose of opioids. And I would as an ER doctor, and now as doing day clinic medicine, urgent care, I do write for opioids. Okay, they still have a role, and that is in the treatment of acute injuries. And that's when they have an acute injury, where they have a surgery, that's a very effective time for nurses as well, to providers, to say these medicines are for this short period of time only, and longer than that is a risk. So in that context, nurses have a lot of interaction with patients in those contexts.
We have one last question in the best interest of time. It's from Adriele Fugal, one of our AHEC alumnus. How important is it to integrate mental health services with addiction treatment programs?
I'm not sure you could. I'm not sure you can do it without it. I think, especially we see the numbers of, like, the correlate, with PTSD, it was like, again, 70% substance use disorder correlating with PTSD. You've got such a correlation that mental health disorders, from anxiety to depression, those things that result in emotional distress, which leads to, again, patients wanting to try something, anything to give them some relief, even if temporary, and even if ultimately long-term counterproductive. I'm not sure you could even do one without the other. They have to be done together.
Thank you, Dr. Johnson. This has been very informative and educational presentation. Your expertise and dedication has been really, truly inspiring to all of us as we continue our ongoing efforts to combat this crisis in Utah. Dr. Johnson mentioned some books during his talk, along with some book suggestions in the chat. I want to let the AHEC scholars know that this can count as elective credit. Our keynote speech will be uploaded to our AHEC channel, as well as, to our AHEC webpage, as well as to our YouTube channel. I encourage you to revisit this talk, to share it with your peers as well. Thank you again, Dr. Johnson.
No, it was my pleasure. Thank you again for inviting me and having me a part of your event. It was my pleasure.
Thank you so much. We will now have Adriele Fugal lead us on a trivia break. There will be three prizes for your participation, and you must be present to win. With that, we give the time now to Ms. Fugal. Thank you.
Hi, thank you, Tatiana. Can everybody hear me?
Yes.
Awesome. Okay, so we will play a game. Kahoot, I hope all of you have played this game before. Can you see my screen?
Yes.
Yes, awesome. Okay, so the way that this game works is first you need to have access to the QR code, or second, let me just minimize my screen here. Okay, let's start right here. So you can either go to join Kahoot at www.kahoot.it, or you can scan the QR code. And the game pin is 833-1580. And you will have 20 seconds to answer each question. Just remember that the faster you answer the question correctly, the higher your chance to get on the leadership board. And for our 3 participants who are in the leadership board, first place will receive a $50 gift card, Amazon gift card, I should say. And the second and third places will win a mug and a shirt. I will give you a few more minutes so everybody can have access to the game. This will be exciting. We have 43 people so far. I'd love to see more. Please join. Okay. 47. How many more minutes should I give? Maybe a few more seconds? Okay. Okay, we have 50 people so far. Okay, let's start. Okay, first question. The number of deaths attributed to opioids per year in the US is best approximated as 10,000 to 20,000, 30,000 to 50,000, 60,000 to 80,000, or over 80,000. Five more seconds. Okay, the correct answer is over 80,000. Great job, everyone. Next question. The scoreboard is showing that McKenna is winning so far. The opioid most immediately responsible for opioid deaths in the US currently is hydrocodone, heroin, fentanyl, or oxycodone. And the correct answer is fentanyl. Okay, Sarah is leading now. Exciting. Next question is, what is Utah ranked for age-adjusted suicide rate in the US for the year 2022? 7th, 3rd, 20th, or 17th? And the correct answer is 7th. Leah is now leading. What Utah-based initiative focuses on reducing opioid overdose deaths through education and distribution of naloxone? Opioid Safety Coalition, Utah Naloxone Project, Utah Overdose Prevention Program, or Safe Utah Initiative? And the correct answer is Utah Naloxone Project. Liv is now in the leadership. And last question is, which demographic group in Utah has the highest rate of suicide, a significant public health concern in the state? Adolescents, youth, young adults, mid-aged adults, or elderly? And the correct answer is young adults. Okay, let's see the podium. Leah got third place. Congratulations, Leah. Asnith got the second place. Congratulations. And first place is Liv. Thank you so much for participating, everybody. And we'll be mailing the gifts, correct? Yes, we'll be mailing the gifts. Thank you so much for participating.
Will winners please message me your email address so in private so that we can contact you to deliver your prizes. Thank you so much. We now will break out to our sessions.